Bismillahirrahmanirrahim. Today I will discuss, my dear students, about the oral tumors, and I have divided my lecture into two parts. In one part, I will show you the presentation about the tumor arising from the epithelium of the mouth, and in the second lecture, I will briefly describe the tumors of the jaw and the tumors of the salivary glands. Two types of the salivary glands, minor and major, and we will discuss all these things in the second lecture. I'm sharing you presentation, tumors of the oral cavity, and if you have questions, you can ask and you can put your questions in the question box. So if you recall your memory, the histology is very important to understand. I will try my best to make this lecture interactive with anatomy, with surgical anatomy, with histology, because to understand the tumor, these all things are very important. On the on the left side, you are looking this mouth, and in the mouth, this is the hard palate, dorsal surface of the tongue, and this is the gingiva. This epithelium is lined by stratified squamous epithelium, and it is keratinized. Keratinized means it contains keratin protein. It is a very tough layer. It, it's secreted to protect this mucosal parts. And then this mucosa is divided by the basement membrane. Basement membrane again is a tough connective tissue layer. And the understanding of the basement membrane is important, that if any cancer or tumor is limited above this basement membrane, it is called carcinoma in situ. And if it is crossing this tumor and reaching to the lamina propria, in the lamina propria, you are looking this blood vessels, nerves, and the immune cells and other connective tissue. And if the tumor is involving this area, then it is called invasive tumor. And invasive tumor, again, surgically we divide into minimal invasive. When the tumor is up to the lamina propria, and if it crosses the lamina propria and reaches to the other layer, muscular layer, it is called widely invasive tumor. This was the importance of the basement membrane. The terms we will use: metaplasia, dysplasia. Dysplasia again is mild, moderate, and the severe. Again are grade 1 dysplasia, grade 2 dysplasia, and grade 3 dysplasia. Grade 1 dysplasia is called mild dysplasia. When, if suppose 1, 2, 3, 4 layers, if small portion of this stratified squamous epithelium is showing enlargement of the nuclei and suspicious histology, we will grade it mild or grade 1 dysplasia. About 25% of the whole epithelium, when it is involved, it is called grade 1 dysplasia or mild dysplasia. If the dysplasia increases up to the 50% of this epithelium, then it is called moderate or grade 2 dysplasia. And if the dysplasia increases almost 75% of the tumor, then it is called grade 3 or severe dysplasia. Carcinoma in situ mean when 100% of the epithelium is showing suspicious pathology with an enlargement of the nucleoli, enlarged nuclear cytoplasmic ratio, and mitosis and other things. This was just to understand you people, the histology, importance of the histology. Not only in the mouth, there is keratinized stratified squamous epithelium. If you see the buccal mucosa, soft palate, floor of the mouth, lateral and ventral surface of the tongue, it is comprised of, epithelium is comprised of non-keratinized. In this, it does not mean there is no keratin, but it produces very small amount of, with which provides the very less protection, very tough area. And again, other things are similar. Soft, uh, uh, soft palate and retromabotine. If you see here, anatomy of the oral mucosa, this is the hard palate, then the soft palate, then and this is the gums, this is the buccal mucosa, this is the retromolar, last molar teeth, retromolar tricone. It makes a tricone between these areas. And then this is the anterior two-third of the tongue, and the posterior one-third of the tongue. This is the lips and floor of the mouth. The squamous cell carcinoma, most commonly, I will show you here on lateral surface of the tongue and floor of the tongue. Most common site of the tumor arises. Another is the oropharynx. Oropharyngeal carcinoma is another important anomaly that you will see, that disease in this areas. So the first tumor, that is the benign tumor, that is called the fibroma. This fibroma, you are looking here in the cross. This is a rounded, circumscribed, looking reddish. This may be due to some chronic irritations. This may be due to some chronic disease. Chronic inflammations may produce this fibroma. And this is just to connect this. It does not involve the epithelium. It is just a collection of hyperplasia of the connective tissue. And then it is always present on the buccal mucosa along the biting site of the teeth. So the treatment of is completely surgical removal. Another tumor that you will usually see, this is just a larger, more reddish, because this is called pyogenic granuloma. This is pedunculated mass on the gingua, on the gums, may be seen in the children, but usually we see in the young adults and the pregnant women. These are richly vascular and typically are ulcerated. You are looking at the ulcerations, it splits. In some cases, growth can be rapid and raise the suspicion of malignancy. That is very important to remove it and to make the differential diagnosis. And the treatment is surgically, complete surgical removal of this one. This is the histopathology. You are looking at the dilated blood vessels, tense proliferation of the vessels, making the granulation tissue, and These are the spindle cells. Very interestingly, that these can regress automatically, even sometimes, some cases, without treatment. Sometimes may ossify. The treatment is complete surgical removal. These two, leukoplakia and erythroplakia, are called pre-malignant lesions. If the examiner asks you, if in MCQ question, there is about the question is asking about a pre-malignant lesion and you see leukoplakia and erythroplakia, these are called the pre-malignant lesions. Leuko mean white, plakia mean growth. A white patch or plaque that cannot be scratched off and cannot be characterized clinically or pathologically as any other disease. This clinical term is reserved for the lesion that arise in the oral cavity in the absence of any other etiology. Still, we do not know either the tobacco or pan or betel kids or some other things are involved in the leukoplakia. Approximately, it is seen in 3% of the world population in the mucosa and 5 to 20% in the pre-malignant lesions. And if we do not treat it, they may progress to the squamous and carcinoma. It's very important to thus, until proved otherwise by means of histology evaluation, all leukoplakia must be considered as cancers because they can progress to the squamous cell carcinoma. Very, very important for the students. Another erythro means reddish, blood-like. A red velvety, it is just like a little bit more serious as compared to the leukoplakia. Possibly there is area of erosion that may be flat or slightly depressed or rapidly sometimes projects from the epithelial surface. These are epithelial origin. Fibroma, I told you, is the connective tissue tumor. Granuloma pyogenicum is a connective tissue tumor. As leukoplakia, erythroplakia, pre-malignant lesions, these are due to hyperplasia of the epithelium. They may be associated with a high risk of transformation of the malignancy as compared to the leukoplakia. Each almost in the old age and middle age and more commonly seen, predominantly seen in the males. Very important thing is that I told you there is no etiology up till now we know associated with the leukoplakia, maybe due to some inflammation, maybe due to some ulcers, maybe due to something else. But in erythroplakia, we know that tobacco, use of tobacco, cigarette, pipe, cigar, chewing up the tobacco is the most commonest risk factor with leukoplakia and erythroplakia. Here you are looking in A, this is the A, this is the B, clinical appearance of the leukoplakia. You are looking here. And histologically, you will see that here, this is the hyperplasia of the epithelium, but this is intact layer. You can see here few inflammatory cells. You can see few mitosis, enlargement of the nuclei, but still this is not malignant. This is the characterized by the cellular pleomorphism and the loss of normal maturity. Leukoplakia includes a spectrum of histological features that I have shown the previous picture ranging from hyperkeratosis, when the keratin amount is increased, acanthosis, when the whole layer of the stratified squamous epithelium is increased, but they are arranged orderly, while in the dysplasia or in the malignancy, there is disordered arrangement of the epithelial cell. Leukoplakia and erythroplakia may be associated with dysplasia or may be associated with carcinoma in situ. Here you are looking different types of the cell in the mucosa, and the tumor arises from all these cells. Squamous cell, I told you, the most commonest uh, tumor arises from squamous cells, lining the lips, tongues, gums, and these are the melanocytes. They can arise from, they can give in the hard palate. You can see the melanoma is no doubt rare, but can be. Other 5% tumors include the melanoma, adenocarcinoma. These are the glandular epithelium, and then you can see this is the extranodal lymphoma. You can see the salivary gland tumors are also present. Squamous cell carcinoma, as I told you, the 90% of the tumor, other 5% tumors are the adenocarcinoma, salivary carcinoma. We'll discuss later on. The squamous cell carcinoma is more aggressive tumor with poor prognosis, almost 5-year survival in 50 year 50%. Very, very aggressive tumor in that. Why? Because in Pakistan, especially, the patient presents to the doctor in very late stage. The stage is very important to assess the prognosis of the patients. Yes, very important, the surveillance and early detection uh, of the squamous cell carcinoma to improve the prognosis, to improve the survival. And in the sometimes, if you are treating the squamous cell carcinoma, you can see the uh, second cancer. That is why sometimes treatment of the primary tumor, almost 35% chances to develop at least one new primary tumor in these areas. These candid tumors can be particularly devastating for persons who are initial lesions. So it is very important, the surveillance, keeping the patient under observation. Another, what are the different symptoms? Patients of the oral mucosa, you will see the numbness. The patient will complain that there is a change of the sensation. In advanced cases, patient can see, describe that there may be hoarseness of the voice, pain, difficulty in chewing, difficulty in swallowing. Sometimes there is a lump maybe painful or maybe painless. These are the different factors: tobacco chewing, alcohol abuse, chewing of the metal kits, pawns, ultraviolet radiation, exposed to the metal dust and chemicals, especially phenoxyacetic acid, vitamin deficiency like iron deficiency, Plummer-Wilson syndrome, immune deficiency, another cause. Two, human papillomavirus 16 and 18 are associated. Now, what is the pathogenesis of this tumor? Tobacco contains so many chemical carcinogens that causes the dysplasia, and from dysplasia leads to the carcinoma. Alcohol abuse can also change the histology of the oral mucosa that leads to the carcinoma. There is mutation of our tumor suppressor gene, especially P53. Genes that regulate differentiation of squamous cell carcinoma, P63, and Notch1 are responsible in pathogenesis one of the stem cells. In human papilloma virus, very important thing that examiner can ask from you, that the human papilloma virus also causes the mutation in our tumor suppressor gene. There, that is called retinoblastoma and P53. These two tumors, they control the cell cycle. E7 that causes the inactivation of the retinoblastoma gene, and E6 causes the inactivation of it. So this is the distribution of tumor, where lies the most commonest tumors. This is the whole history, this is the whole story about 17% Makkan mucosa, 22%, 32% here, 22% here, 11% lips, 11% palate, 8% vestibule, 5% alveolus, 5% flora. The most commonest tumor, the buccal mucosa and the tongue. This is the location of this tumor. Crossly, you see the ulcers, raised mass that can be firm. You can see the pearly plaques or irregular marks. You can see the rough. If any patient complains the non-healing ulcer in the mouth or gums, especially in the buccal mucosa and the tongue, you consider it the malignancy. Very, very important thing. So this is the histology of this one. This is the non-healing ulcer, a large reddish mass, clinical appearance, and induration areas is there. This is the squamous cell carcinoma. Stages of the cancer carcinomas, grading of the tumor, grade 1, grade 2, grade 3. Grade 1 tumors, you can identify almost 75% of the cells, they are squamous cells. There may be keratin pearls. This slide we can put in the auspice. You have to identify these keratin pearls, hyperplasia of this one, and the tumor is coming down. Tumor is breaking the basement membrane. Histological appearance demonstrated the numerous nests of the cells and islands of the malignant keratinocytes and invade the underconnected tissue and breaking the basement membrane. In grade 1, as I told you, is the good tumor. You can identify the 75% cells as the squamous cell carcination. In grade 2, there is a more loss of differentiation. Almost 50-50% cells you cannot identify. Either these are squamous cell or these are not squamous cells. They are all pleomorphic cell. In grade 3, this is the more aggressive tumor. In this tumor, you will see that almost all tumor cells show the loss of differentiation. So the grading depends upon the differentiation. Another thing is the diagnosis. History is very important. Clinical examination is very important. And some investigation, blood complete examination, you will see the anemia, you will see the increased ESR, and the confirmation is the biopsy. Until and unless you cannot see the cells under the microscope, it is very difficult to diagnose the case without the biopsy. Imaging is no doubt very important. This imaging, X-ray, CT are combined. Imaging, PET and CT scans are the staging is important to for you students. It is only to know the T means the how much the size of the tumor, and N, how much the extent of the lymph nodes are involved, and M means M0, or M, the metastasis of this one. This is uh, Tx means no available information of the tumors. T0, no evidence of the primary tumor. TIS means carcinoma in situ. T1, more than 2 centimeter. T2, 2 to 4 centimeter. T3, more than 4 centimeter. T4, more than centimeter, but involving the other areas of the tissues. Same lymph node, NX cannot assess the tumor. N0, no lymph node. N1, single ipsilator, one side. N2A, single ipsilator, and about 3 to 6 centimeter of the lymph node size. N2, multiple ipsilator, one side. And N3A, single, multiple ipsilator, more than 6 centimeter size is involved. N3, bilateral on both sides of this. So that is why lymph node involvement staging is very important to assess the prognosis of the patients and see is the continuity side of this one. M1, again this one. So this was all about this today's. I hope this lecture will help you understanding the basic concept of the oral mucosa tumor. In second lecture, I will send you uh, the tumors of the salivary gland. You all students are welcome to ask the question. You can put the ask question in my question box. Thank you very much. Best of luck and best wishes.